Good evening, everyone, and thank you for this opportunity to present at the prestigious TCT meeting of Southeast Asia. So I'm presenting from PGIMAR Chandigarh. I'm associate professor in the department, and my title of the talk is Left Main PCI, The Devil Gets More Angry. So the patient is a 55-year-old male with the risk factors of diabetes and smoking who presented to our department 2.5 years back with unstable angina for a month. He had normal LV function and valves at that time. So this was the angiogram around 2.5 years back, where we can appreciate diffuse double vessel disease, which involves the distal left main, proximal to mid LAD, and osteoproximal LCX, which has a long lesion. And also the LCX is the dominant vessel in the patient. So the patient, of course, was offered CABG, but he refused for CABG. And we decided to treat this patient with left main bifurcation. It can be discussed which two stents technique can be used. Of course, this is not a case for provisional, as we have a very long disease in a dominant circumflex vessel. So at that time, we did a pre-dilatation of the left main circumflex. We wired both the vessels, and then we stented from the left main ostium into the circumflex with a drug-eluting stent. And a pot was done in the left main with a 5 mm balloon. And we decided to use the tap technique at that time, considering 90-degree angulation between the left main and LAD, and also a large circumflex, which was chosen as the primary vessel. So tap was done with the 3 mm stent in the LAD, and a kissing balloon inflation was done initially with the stent balloon, and then high pressure dilatation was done with the NC 3.5 and NC 3.5 in the LAD and the LCX. So this was the end result on the left side after the initial about 2.5 years back. Of course, this imaging was not done during this procedure because of constraints, as we work in a government institute, but angiographic the result looked appropriate. His biomarkers were negative at that time. There were no new ECGs, and he had negative RT-PCR. So this was on the left side of graphic result of his first procedure. And this is the angiogram that we saw during the COVID pandemic last year. So clearly he had a very tight restenosis in the distal left main, which extending into the LAD and the LCX. We don't appreciate much thrombus here, but his biomarkers were also negative. So this is the RAO caudal view depicting the same, with very tight restenosis of both the vessels, and the LAD distally is patent with no new lesions, and the right is a small non-dominant vessel, as you can see, and there are no collaterals from this vessel, the left system. Of course, the CABG was a better option to start with, and of course, at this time, I think CABG should be the only option. But at that time, there was a COVID pandemic, and we did not have an option of offering the patient CABG, and he was having recurrent rest angina, so we had to intervene to the best of our ability. So we decided to rotablate, to expand the stents, because restenosis always has a combination of new intimal hyperplasia and stent under expansion. So it was not a very heavily calcified lesion, so I don't think IBL would have worked. So we thought that we'll use a 1.7. So after removing some plaque in the left main duality, the patient was more stable. And then we decided to switch the wire into the circumflex and use the same 0.75 mm burr into the circumflex. So after some manipulation, because of the angulation, we were able to cross the burr into the circumflex, as can be appreciated on the right side. So after we did circumflex rotablation, the flow to both the vessels were better. And then we did an IVUS to both the limbs. So this is the important IVUS finding at the circumflex. We see there is a lot of new intimal hypoplasia, but this is, mind you, after a 1.75 burr, and there is also stent under expansion. And the residual lumen area was only 2.82, whereas the vessel is almost 14. The POC looks all right, but there are no stent struts in front of the LED. That means the initial kissing balloon was effective, and the left main IVUS findings were satisfactory. So we followed up with cutting balloons into both the circumflex and the LED. And since we thought that the recoil and new intimal hyperplasia was significant, we thought that we'll restent the patient with 2 stents. So after some further plaque modification, we decided to do a mini crush with a 4 millimeter stent in the left main to circumflex and a 4 millimeter stent into left main to LED. A pot was again done with a 5 millimeter balloon, and a final kissing balloon was done with the 4 and 4 millimeter balloons in the LED and LCX. So following this, we did an IVUS run into both the limbs. And this is the LCX ostium post. We got an area of MSA of 8 millimeter square. The circumflex proximal was also more than 7. And this is, you can see the LCX ostium pre and the LCX ostium post. So there was significant improvement in the ostial area with a final area of about 8. And this is the LED ostium MSA of about 9 millimeter square. In the mid left main, we could get about 13, and we could get about 11 in the POC with no stent struts in front of the carina or the bifurcation. So this was the first angiography after he restenosed, and on the right side, we can see the final picture, which looks quite acceptable. And this is the caudal view. And again, we can see the caudal view on the right side. So it looks very acceptable with good stent area. The patient has been doing well for the last while, and he has been on regular follow-up and thankfully has not restenosed again. So left main interventions are always a challenge, and LCH ostium ISR is probably unavoidable. It is the Achilles heel of PCI, as we all know, but we should all try to do our best at the LCH ostium. Imaging should be encouraged to get the best possible result. However, it is not possible all the time. A CABG is the best option, in my personal opinion, for left main ISR, especially if there is a good target for the lima. But in some situations like this, because of the environmental situation also, we could not offer him the best therapy of CABG in this case. Rotablation is very useful to treat stent under expansion because it helps in heating up and can help in further dilatation of the stent with a non-compliant or a cutting balloon. But rotablation should be used with caution into very angulated side branches like the circumflex, especially when it has been stented. You need to know where the wire bias is, and you need to use it very carefully. Thank you so much for your attention, and I'm open for any questions. Thank you.
Himanshu, interesting, very good case. Some
hello, sir. Good evening.
Yeah, good evening, Himanshu. Nice to see you again.
Yes, sir.
Right. So I think we have a couple of minutes, fortunately, for your case, and quite interesting. Your end result was good, the way you handled it. And of course, there are some issues, plus and minus. There is no definite answer to all this. But you rightly said, whenever you do left main, especially bifurcation, imaging for the first time also should be good. If at all, we have to compete with the surgeons in long-term results. Anyway, it was possibly a scheme patient, and it was done in the way as you showed. But nevertheless, there also, I would have thought that possibly the circ ostium requires a good plaque modification, and so that the restenosis rate are less. And because it is an ostium, cutting balloon or scoring balloon, something of that sort would be an ideal thing, you know, to whatever size you think. It was 4 on IVUS, you could have used 3 also, or 3.5, which would have given you 9 millimeter or 12 millimeter of area. So that was at the first time. Then at the first time you chose a T-tap technique, right? For the, but there was an LED D1 bifurcation lesion also, or you extended that you covered one single stent right up to there.
Yeah. So in the first, it was a T2 for the LED, and the LED diagonal bifurcation was not treated. Only the LED was treated, and the diagonal was patent after the LED stent. So it was not touched, and it remained patent at follow-up also.
Yeah, very good. So basically, we have now addressed the point of first intervention. which you did at T also is an option. Of course, the long-term results of T-tap technique, if you were to compare with any DK crush, is inferior in the study at least. But T-tap also is a good alternative. And even in the EBC main trial, T-tap technique also was used both for bailout in provisional as well as in the elective two-stent strategy. Right. So now coming to rotablation in that, what I could say is that rotablation was used more as a debulking device in your case rather than a plaque modification device, because there was no calcium on the IVUS. So it was more of a debulking device, if I'm not mistaken, right? So now rotablation in ISR as a debulking device has been used in the past. But after the advent of drug-eluting stents, people have had found not much of advantage, and therefore that as a standard technique has been given out. But nevertheless, it is still done by many operators when you have small vessel ISR. Because in small vessel ISR, what happens is that there is a limit to which you can expand the drug if you have left the restenosis, the hyperplasia part. Okay, so you debulk that and then use a cutting balloon or maybe a scoring balloon or high pressure balloon, then put in a stent and try to give a better lumen. But for such large vessel, I do not know, but nevertheless, I just said that this is what the data is, and there is no harm if your stent struts is not coming in the way, because in the T-tap technique, you know, some one or two strut could have been out, but I think the restenosis was so great that there was no way possibly it would have been touching the stent struts. So that is T-tap. And then you see, using an OPN balloon in ISR, I think gives much better. Now you see, you put in a 4 millimeter stent, right? So which should have given you at least 13, 14 square millimeter ideally. And you landed up with 8.5, right? I would have used an OPN balloon at high pressure to get as much as possible, because stent under expansion, you said under expanded stent in the first instance, and therefore on the second time when you use the IVUS, you saw that but the second stent which you put in also, I think you have to also see not only the area lumen which you are getting, but the residual plaque behind that. If that is crossing more than 65% or 60% or even 50%, you should further try and see that you get better lumen. So that was another thing which I thought was also could have been additional. Of course, the end result with you was good. So I don't think we have anything to argue about. And if you have the long-term results better, hopefully this patient should do well for the future. Anything else somebody wants to ask or comment or raise a question, or you have to say something? What do you think is...
I just wanted to say,
and
sir,
what about that high OM? That high OM also looked quite good in size. Was it okay at the end?
Yeah, it was okay. It has TIMI-free flow at the end. What I would say is that there is also the circumflex ostium is also very notorious for recoil. Now, at the first instance, we saw a 3.5 NC balloon dilating fully at the circumflex ostium while the first T and tap. But in the end, when we did an IVUS 2 years later, the area was only 2.3. So there is no doubt in my mind that even in the first instance, we would have got an area of at least 6, 7, but it came down to 2. The stent area, not the lumen area. So there is a recoil also which happens at the circumflex ostium. And coming to the point of rotablation, I think I used a 1.75 burr. Ideally, for the LED, I would have used a 2 millimeter burr, and for the circumflex 1.75. But to save money, I used the same burr in both vessels. So if you use a large burr, then it also heats up the stent struts and sometimes helps in dilating the stent struts with a balloon, even for ISR patients. Of course, small burrs don't work, like a 1.25 over 1.5.
No, if you are going for debulking, then there is no point with small burrs unless it's a calcified lesion and undilatable lesion, then that's fine. But the point is well taken, and therefore, as I said, in the first instance, maybe plaque modifying or something
Yeah.
like that, scoring cutting
Cutting
balloon
balloons
would have
are
given you a better
would have better.
MLA. And late recoil, that also is a factor in osteal lesions, especially the circ
Yeah.
ostium. That also, and
And I just wanted to also add in the end, sometimes even in the end we got an area of 8 millimeter scare, and you rightly pointed out that it should be 12 or more for a 4 millimeter stent. But sometimes when it is not a de novo lesion, there is a stent outside. It is very difficult to expand it fully, because it is even difficult to expand a native vessel. But to expand a stent, a metallic stent which is lying there, it becomes even more difficult. And then if you go very crazy high pressures with the 3.5 OPN, sometimes you may deform your LED, because the carina will shift all towards the LED, and you will not expand the ostium of the circumflex sometimes, and you may also have a rupture. So it becomes sometimes, I don't know what is the safe and
no, of
perfect
course,
and
nobody
safe
knows,
result.
Himanshu. We don't have any guidelines or cutoff like this. This is all by experience. In this case,
Yeah,
so the second time when you did stenting, what was your strategy of two
we
stent?
did it. We did a mini crush.
You did a
We did
mini
a mini
crush.
crush.
Yes.
Yeah, yeah.
So you
We did
crushed the
a
LED
mini
stent?
crush. No, no, the circumflex end. So in the second procedure, I made the circumflex as the side branch. So I
Okay.
just put 1 millimeter into the left main, and then I put a left main to LED,
Yeah.
another stent.
So
Yeah,
maybe before crushing the circumflex stand, we could have modified that by an OPN balloon.
yeah,
That
maybe,
that
yeah.
that yeah, that would have avoided. I'm just saying. See, I have used OPN in such circumstances, and I found it very useful, especially in ISR first stand coming back. I would not put a second stand unless I have got a good area after doing all this plaque modification or debulking techniques, and then try and giving and good before you, because after putting a second stand, then to stretch it further is going to be difficult, because your
Very
balloon
difficult.
has to give pressure to your
Yeah,
second stent and the first stent. But
yeah,
before putting the second stent, if you do, maybe then that would
yeah.
give better results rather than this. So nevertheless, I mean, these are all complex cases, and there is no definite answer. One has to go by, first of all, their own preference and experience, and secondly, finally, what is happening on the table, because you have to switch strategies when something is not going as per plan on the table, or you find imaging
Yes.
something unusual. So I think well done case. Thanks, Himanshu, for that interesting
Thank you.
case and interaction. So now we